and potentially we can publish the outcomes either after the session with an email to all the attendees, or maybe we can plan another catch-up, whether it's an online or an offline session, where we can discuss these outcomes. And some of the most important issues that we have encountered in school health particularly was the privacy and consent process. As you know, for every student in every school, in order for us to be able to provide healthcare services like any other patient, we will have to get their consent. And usually there is a universal consent that is provided by DHA. This is mainly a question to Dr. Hanan and Dr. Fathia and the rest of the regulators on. As of today, we do not have a clear consent process for telemedicine. So do we include telemedicine in the same consent form that is universal and we are already using for schools in general, or do we come up with a new consent form? So that is one of the dilemmas that we've been thinking about, and we're trying to tackle with our partners as well on the school end. I would love also to think from an aviation medicine perspective, whether you have approached or you have encountered a similar problem and how you tackle it and how we can tackle this issue across the board, across different areas or domains that we are thinking telemedicine will expand or will further mature. One of them is telepsychiatry, for instance. So that is one question. The other question is on the medications that can or cannot be prescribed by telemedicine. And as you know, as it stands today, we're still not allowed to prescribe controlled medications. And if I were to ask the group, who is in favor and who is not in favor of prescribing controlled medications through telemedical pathways, and I'm sure there will be some discrepancies and different opinions, different arguments around this very crucial problem. And as I've shared in my presentation, there are colleagues and healthcare professionals around the world who are investing a lot in psychiatry, where controlled medications can actually be prescribed. In some cases, cannot be delivered through e-pharmacy pathways. In some other instances, they can be prescribed and they can be delivered. And this also one thing that I was discussing with Dr. and also very briefly with Richard today, is if we have a patient who gets a seizure on a flight, can we first have diazepam readily accessible on a flight, or any of the other similar controlled medications? If we put the right regulatory processes in place, can it save a life? Is it important? How do we monitor? How do we track? How do we contain any potential for misusing or abusing the medication? So some of these questions that I know that all of us can answer together, leave it to the group. It will be an open discussion. Maybe we can come closer in the tables and share some thoughts and ideas across the same lines. And also would love to hear from you on some of the other challenges that we're facing and you could not think of ready solutions to implement right away, and it would take several stakeholders and a multidisciplinary approach in order to be able to solve it. So that was the intention behind this piece of the workshop, and as Arun mentioned, this will be the last chapter of this workshop, and then we can go out for the next lunch, and then going to wish you the best in future sessions. So if we could come closer in the tables, that's my suggestion, and have a 10 to 15 minute discussion. We can start with the questions that I mentioned, as we are facing these challenges on a daily basis, and we know that those are critical issues that we are facing every day, and we are trying to solve. And then we can think of any other questions, and with kind consideration of Dr. Hanan, we can wrap up the day and she can maybe deliver a closing remark, if that's okay. Is that okay with everybody? The new consent process, or do we include telemedicine in the already existing form and comprehensive universal process? Maybe you want to...
I think this is a main issue at the moment because we have guidelines that speak of the consent form with what are the fundamental requirements for that. These would be just a concept or an idea what we expect you to have on a consent form, but you can actually tailor your own consent form. In our telehealth standards, we do mention the requirements for a consent form, which are a bit different in terms of what kind of requirements we need, what sort of approvals, and how it could be delivered. Now, this is just as a guideline, and then you can actually tailor it to whatever, customize it to whatever situation you're in, as long as you meet the minimum requirements that we have. And I think we had a discussion about that because do you want to have a universal consent form where it would just address that this is a telehealth call and it has all these requirements, or you want to tailor one specifically to a certain, for example, condition when it comes to mental health, or maybe for schools, and just customize it.
IATA guidelines, the International Air Transportation Guidelines, there's no doctor-patient relationship that should be established unless it's international guidelines. There is, however, a consent for care. So if there's someone who's conscious on board and we are providing care to them, we do have a consent form. And it's more universal, if that makes sense, in terms of accessing care. You don't have to specifically say telemedicine, but you are accessing care from our crew and whatever system that we have on board. So it's very important to state that there's no doctor-patient relationship being established, and that's how the framework is. Second thing is around our unaccompanied minors. Many in the aviation industry have had that challenge. When you have unaccompanied minors travel who are then sick, and how do you then access healthcare? We are also approaching that differently and asking parents before flying to. There's a form that exists already in terms of declaration, and if someone is unwell, we assume care once they're in our custody that we can provide that care for them. We're trying to improve that process, make it a bit more robust, so we're in the process of doing that as well. But that's the other challenge that we encounter as well, unaccompanied minors, making sure we understand their allergies, their access to care. And I like, from the educational perspective, the consent form is really nicely detailed about what parents have to sign, being a parent myself, about what sort of care that can be accessed from the school, and it's a similar sort of situation. They're in custody of the airline, so therefore we have access to give over-the-counter medication or something that can be treated. If someone's unconscious, and we do encounter lots of passengers who might be unconscious as well, we assume that we can activate care as an emergency situation in any scenario.
Thank you, Dr. I think that's very interesting. We can't hear you.
Now, I was just commenting on a discussion about having an unaccompanied minor on an airline industry. It's a different scenario when it comes to school, for example, where as a parent I would give a consent at the very beginning of the year that my children have received such and such care, or I'm allowing them to use telehealth when needed and that sort. But when you're traveling, and not even in traveling, you get those minors that are now very highly tech that they would want to use care and they would be able to access care. Maybe not through a telehealth, but maybe through AI technologies. And where does that play? What's the dilemma around that area? And who's accountable for that? That would be maybe interesting. So how do you tackle that in space? In an airline industry, do you expect them to is there a consent that this minor will be traveling by himself, or how does it work?
Yeah, thanks. It's a really interesting question. I think if they're using the technology independently, we probably wouldn't even know. They only cross our path when they access care from the cabin crew. So if they're unwell and they need assistance from the crew, then we're aware of it. There is a general form, so if you've ever had your kids travel with Emirates unaccompanied, we do have a declaration form in terms of care and what sort of conditions they may have, and we do have a policy around that. Like I said, we're working on making it a bit more robust. Some of it might be aligned with how the school has it really well, nicely detailed. So we do have a process, a general declaration form once they're in our custody. But it's an interesting question, because if they do access their own care, then we probably wouldn't even know about it. But if they do need the assistance from the crew or perhaps a medication from our medical kits, just so that they're stable enough until they arrive. Then we're interacting to them.
Thank you both so much. Anybody from the schools want to chime in on this one?
Thank you, Dr. Tarek. So we'll share our real life experience that, and as Dr. Khulud on the panel pointed out, it's very important that we put our parent hat on before we make any decisions regarding children in a school setting. And what we did during the implementation of telehealth services, that we shared a consent, we developed an internal consent form that went out on behalf of general education, was shared with parents, and we included a brief introduction to the system on that consent form, informing them what it would entail and what exactly is the exposure that is going to be involved and their child will have when they are involved in a telehealth consultation. It is then up to the parent, after receiving that information, whether they accept it or not. It's very important because they're a very important stakeholder of this entire equation. In order for it to work, they should feel like their voices matter and they are heard. We wanted them to have this consent because the general consent that we do share with them, it doesn't specifically mention telehealth services, and the mode in which it is delivered is somewhat different than the conventional setup in a clinic. So we felt the need to share it, we implemented it, and the turnout of the consent was very, very high. Most of it was positive. It's a very low number where the parents said no. So from our perspective, yes, the consent is very important.
Doctor, we have another participant who would like to.
That's all right.
Thank you for your presentation. And we as a school doctor, we have a problem for telemedicine pads. And because for me it's very important, physical and mental, not for all mental health of the students. So I think we need more workshop, not only for a school team, but also parents. And also another thing should be insurance support by DHA. Because most of the students or the students, they don't have insurance, and I think they have problems with finance.
Thank you so much. I agree with you that we definitely need to raise more awareness and we definitely need to involve parents in the process and engage them as we are building this up. However, as I think we are all aligned, even when we started telemedicine in general, and I have mentioned this a couple of times in this workshop, the adaptation was not as high as we are seeing today. And we know that this is the future, and of course telemedicine is not here, it's not here to replace the doctors at all. That is not the intention, and it does not have the capability to even replace the doctors. However, it's there to complement, to assist, to widen the scope of service, and to provide more access to students, more access to schools, more convenience to parents, and preserve the continuity of care as well. So I couldn't agree more. 100%. We need more awareness. We need more workshops where we include all stakeholders, including the parents as well, hearing their feedback, and Dr. Mira's points as well. I agree that it definitely should be a concept process. However, I would still debate whether the telemedicine as a care model, because it's a care model, patients are having access to the same quality of in-person, whether it should be a separate form or included as part of the same. It would be one consent form, one consent process that is telling the parents, look, we will take care of your child if they fall sick on school premises, and they will have access to X, Y, and Z. They will have access to the on-site doctor, they will have access to the telemedicine doctor, they will have access to their screening and vaccination, etc. So all of these nuances we'll keep exploring together, and we will keep working closely in order to reach the best answer. There is no one correct answer, and that's why we're having this session, and we'll definitely get there as we work more collaboratively. Any other feedback? Any other thoughts on the same matter? Alright, so we'll move then to the next question that we have we were thinking about, which is a very crucial question on what are the medications, what is the formulary of pharmaceutical medications that can be kept in school and the ones that can be kept on an aircraft, and whether or not it will add benefits to patients to have access to a tele-prescription or an e-pharmacy of some of these medications, with a focus, of course, on some of the controlled medications. We are all, I think, aligned on the primary care formulary, which is very straightforward. However, when it comes to controlled medications, this is where I think the regulations is evolving and will continue to evolve in order for us to be able to deliver some of these benefits to the patients. So we'd love to hear your thoughts. Richard, I know this is a matter that of a question, we'd love to hear your feedback.
We'll break the answer into two pieces, and I'll give the technical piece to Dr. Azim in a second. One of the challenges we have is that there's a regulatory requirement on an international basis for us to have certain controlled drugs carried on the aircraft, and in our particular case it's one. And so one of the challenges that Dr. Khulud and myself have been discussing this, and Dr. Azim, about the regulations. So we've got, at the moment, we're having to work with, it will be the GCAA, who are the federal body that look after the regulations, they have their section, and the Ministry of Health, and probably what we think, we already operate off a special exemption. We think that probably they'll codify that exemption, but it will only be for the specific medication. From a technical perspective, I'll leave it with Dr.
Yeah, thank you, Richard. In terms of in-flight medical events and emergencies, why do we divert, which is a very impactful, very expensive decision to make. We do see neurological and cardiovascular conditions across the industry being the top causes for diversions. And specifically, when you look at neurological conditions, a suspected stroke or persistent seizures, so status epilepticus being a reason for severe medical condition that requires diversion. So whether we divert or we don't divert, we need these types of medications to help our patients in flight. And that's been in the industry, like if you remember my history, since the 1980s, 1990s, and again implemented by the FAA. This is an international regulation to have these medications available, not just to avoid a diversion, but to treat before. Even if we are diverting, we should still be treating before it can help save a life. And that's the best thing to do, especially when patients need help, passengers need help when they need it the most. So we work around that. Interesting, I was in Atlanta last week, and the FAA, specifically on a congressional government level, they're looking at modifying the kits as well. They kind of lead the way in terms of that, making it more accessible for airlines, changing what they've had since 2001, which should be, again, maybe industry leading, maybe something that we adopt, but the Civil Aviation GCA here in UAE already have a mandate for what we should be keeping in flight into our kits, so we follow their guidelines, and we can add more if you need to, but we follow strictly here at Emirates.
Thank you so much. Very informative. Anybody else?
Thank you very much for the discussion. With regard to medication, we have started developing this clinical guidelines for physicians. But because we have some situation now in schools, in aircraft, and all these things, we need to think about how we use more nutrition for in those situations. Actually, we as DHA, we are also regulated by Ministry of Health and Prevention. And there are federal laws and regulations with regard to medications, with regard to control medications. Control medication need to be prescribed by a licensed physician, and this is the law is there on federal regulations. So we cannot let the crew or the school prescribe that or dispense that. The other thing, there are a lot of other standards with regard to how to do saving, storing those medications, to make sure that there is no abuse of these medications by the patients or even by the staff who are using those medications. So there are a lot of legislations around control medications. Therefore, in our clinical guidelines, we did not allow yet the control medication, but other medications is allowed based on the clinical decision of the physician. We can think about it, we can raise this point to the federal level. Now we have Emirates drug establishment has been recently established in the UAE. They are responsible in regulating all the pharmaceutical industry. We can discuss that point with them as well, and we can see how we can support your industry. Thank you.
By the federal government, so that's both the GCA and also the Ministry of Health. So the regulations around both the carriage, storage and use of, and we only have one controlled drug, that's who we follow. The second thing is, in reality, we deal with 16,000 emergencies on board the aircraft on an annual basis. So we deal with them every day. We have a team up there right now. All of the cabin crew go through a training system which is about equal to an emergency medical technician from the United States. So it's more than advanced first aid, not quite to the level of paramedical, though in some cases there are some that would have done that as well. And so they work under the direction, as Dr. Azim said, of the medical staff in our network control centre. The second thing is, one of the options you have when you're on the ground is to call an ambulance. There is no option like that. If you're at 45,000 feet transoceanic over the middle of the Pacific, the Indian Ocean or the Atlantic, what you've got on board is what you've got on board. And so that's why the regulations are and the systems that are in place operate the way they do. Oh, just another quick point on that. Cardiac arrest is very interesting. We actually have one of the highest survival rates for cardiac arrest in the community, and that's because it's so quick. And we have very sophisticated medical equipment. We've got the DFibs, we've got the access to the medical care, the direction, and also the trained staff.
Thank you, Richard. Thank you, Dr. Zain. Any additional thoughts? Yes.
Hi everyone. Hi everyone, this is Dr. Nazish. I am currently practicing as a school doctor at Citizens. I want to just add in one thing. Recently, the clinical guidelines and standards for educational and academic settings, there was an additional drug which is the controlled medication drug Diazepam that was added on to it, right? After that, the school doctors were expected to arrange the drug in the school setting. It was a very challenging process. Number one, why? Because there was no clear indication when it has to be given. Knowing that any child who is already diagnosed with such a condition has to come with an individual healthcare plan. Number two, the process of registering onto the NPCM, which is the National Platform for Controlled Medication, it was very difficult. There was no guideline. I know there were some tutorials shared with the doctors from I think the but even till now we haven't done the proper registration. So it's not only about, like Dr. Amira, she mentioned that who's the one who has to administer the medicine. So we got the rectal tubes, the gels. I have it in my clinics, but up till now we don't have any clear indication or any guideline from DHA as to when it has to be given to the students, or how is the whole process to generate the inventory onto the platform And we got lucky because when we had the inspection, we already had the medicines. So the inspectors were happy, but other schools are still not able to arrange those medicines. Because I personally got it from American Hospital Pharmacy, but other schools, even if you tell them that it's a requirement by DHA, they do not understand, and it's a very...
Version 4.1.
Yes, that's what I'm saying, the latest one.
The latest one is version 4.1. It says it no longer requires the requisite.
But it's not being followed, that's what I'm saying. It's the one that was revised. We had the school health section inspection just a couple of months back.
So the
and then we
were
were
not aware of their revised.
Yes, that's what I'm saying, because a lot of schools don't know that, so maybe something has to come in a more clear way from DHA so they know that everybody's on the same page.
Actually, there's a lot of removed now from the latest standards, but we'll be considering the point about making sure that it's all alignment between the schools and our inspectors as well, regarding to any updated requirements and our updated standards. Thank you for raising this question.
Thank you, everybody. I think we end the session here with all of these great thoughts and insights. And there are some questions that remain, some more discussions that need to take place before we make some of these decisions. And it will be very interesting to see how the regulations, how the guidelines, how the clinical practices will evolve over the next couple of weeks, months, and years. I want to end by very wholeheartedly thanking each one of you for your time today. It has been an absolute privilege and an honor to go through this workshop with each one of you. Would love to connect after. Would love to keep collaborating and working closely on touching people's lives, creating a huge impact, and advancing healthcare in general and digital health in particular. Before we adjourn, Dr. Hanan, a special thank you to all the support that you have shown us, and maybe if you want to say some closing remarks.
A special thank you actually for everyone, a special thank you for TruDoc and Dr. and his team. It was a wonderful workshop. It was a very fruitful meeting and inputs and insights on telehealth, and I think we'll take all your points under our consideration. Thank you for all speakers, Mr. Richard, Dr. Aviation, Mr. Mira, and others. I believe your inputs and your case use it's enlightened our brain, how we can think further and how we can draw the roadmap for improving our standards and our care in the body. Thank you very much for everyone.
Thank you very much. Before we break for lunch, I would request everyone to please scan the QR code and finish the survey for today's workshop. That's the very last request we have, and after that it's warm food and break from here. Thank you.
Where is
The lunch is served right outside the banquet hall. Thank you.